Okay, I hope you can see my screen, and let's start. The main aim of current lecture is to understand the general approach to the poisoned person. We have four questions to discuss. Firstly, I'll give you a general approach to the poisoned patient. Then we go to the methods of treatment. In the part of antidote therapy, I'll show you a few specimens of current practice. And finally, you will acquire bits of knowledge in the complex detoxification, including special methods like an extracorporeal detoxification. Let's go to the first question. A few words before it. Most poisoned patients seen in the emergency department are adults with intentional oral drug overdoses. Other common clinical scenarios include accidental poisoning in children, which represent the majority of calls to regional poison control centers. Illicit drug of abuse, chronic poisoning from pharmaceutical agents, environmental, industrial, and agricultural chemical exposures, envenomation, and medication interactions are other causes of toxicity. In the emergency department, it is important to evaluate and recognize scenarios where there may be immediate or delayed toxicity, as well as initiating decontamination, enhanced drug elimination, and administering more focused antidotal strategies when indicated. In regards to a specific patient with a particular exposure, essential historical points include the agent itself, the route of exposure, the amount ingested, and the timing of exposure. Knowing these facts can help make a determination regarding the expected course of care and help to mobilize resources. Oftentimes, the poisoned patient may be altered or uncooperative with the examiner. This leaves the history limited to that which can be gleaned from witnesses, such as paramedics or family, and the information generated from the physical examination restricted to those functions over which the patient does not have conscious control. Historical information must be pulled from all available sources. A family member or friend may offer insight into the circumstances behind the patient exposure, for example, intentional or accidental. Information regarding what medications of substances were available to the patient and the timing of ingestion also is important. Paramedics routinely will bring in all medical bottles present at the scene, not just the patient's prescribed medications. A patient attempting suicide may intentionally mislead the emergency department staff. Other sources of potentially useful information include pharmacy records and previous medical records. Assessing the patient's text messaging history also may be helpful. And you should be like a true detective. Don't forget, all people lie. Poisoned patients are frequently unwilling or unable to participate in interactive physical examination. The toxicologic physical examination, therefore, rests upon observing factors that do not require cooperation to elicit. Many ingestants can cause derangement of the pulse and respiratory rates, as well as blood pressure. Thus, rapid and accurate recording of the patient's vital signs, including a rectal core temperature and pulse oximetry, should be done and repeated at appropriate intervals. The overall level of consciousness, pupillary size, and presence or absence of seizure activity may suggest a particular agent. Examination of the skin and mucous membranes with a particular attention toward discoloration and level of moisture may suggest poisoning by any of several agents. It may also reveal evidence of injection drug abuse, such as track marks or ulcerations from so-called skin popping. A careful neurologic examination focusing on the level of muscle tone, clonus, or hyperreflexia can assist in the diagnosis of serotonin syndrome or neuroleptic malignant syndrome. Finally, certain intoxicants may have particular odors associated with them. The presence of such an odor ought alert the clinician to the possibility of poisoning by one of these agents. However, the absence of a characteristic smell is not accurate in excluding poisoning. Let's speak some issues about toxidromes. It is a very important part in the toxicology. Toxidromes are constellations of signs and symptoms based on autonomic and neurochemical processes that can suggest a particular class of exposure and direct management and therapy. The five traditionally described entities include the sympathomimetic, anticholinergic, cholinergic, sedative or hypnotic, and opioid toxidromes. In addition, serotonin syndrome and neuroleptic malignant syndrome will be described in this lecture. Sympathomimetic. This toxidrome is defined by a state of sympathomimetic excesses, typically causing those effects expected from the fight or flight reaction. Patients are often altered and may be delusional, especially with the ingestion of substituted amphetamines, such as MDMA, as you can see on this plot. Their vital signs are typically elevated and present with hypertension, tachycardia, and tachypnea. They may also be hyperthermic as consequence of an increased metabolic rate. Mydriasis and diaphoresis may also be present. In severe oral overdoses, derangement of cardiac output can occur, resulting in the circulatory collapse and shock, which may be refractory to fluid resuscitation and pressor agents. Anticholinergic. Many pharmaceuticals have antimuscarinic properties, and thus this toxidrome is commonly encountered. By blocking normal cholinergic tone, an alteration in the normal homeostasis balance between the sympathetic and the parasympathetic arms of the autonomic nervous system occurs. This allows the sympathetic side to function unopposed and generates a state of relative sympathomimesis. Therefore, many of the symptoms attributable to the anticholinergic toxidrome, delirium, hypothermia, mydriasis, and cutaneous flushing, share similarity. In contrast, as the secretory glands of the skin and mucous membranes are cholinergically innervated, these systems are typically dry and not diaphoretic, as found in the sympathomimetic toxidrome. The typical signs and symptoms can be recalled by the mnemonic rule: mad as a hatter, hot as a hare, blind as a bat, red as a beet, and dry as a bone. Cholinergic. This toxidrome results from overstimulation of the parasympathetic portion of the autonomic nervous system, which maintains the rest and digest functions. These patients typically have fluids coming from every orifice as a consequence of increased glandular secretion, and present with diaphoresis, urination, meiosis, bronchorrhea, emesis, lacrimation, lethargy, and salivation. Agents of concern are primarily anticholinesterase agents, such as organophosphates and carbamate insecticides. These substances are readily available as pesticides, but they have also been engineered as weapons of mass destruction, typically referred to as nerve agents or nerve gases, as you know. It is important to rapidly recognize this toxidrome because patients frequently die from excessive bronchorrhea, effectively drowning in their own secretions, unless timely antidotal therapy and cholinesterase regenerators can be given. Nicotine poisoning from tobacco can occur in children who ingest detritus, such as used cigarettes or chewing tobacco, as well as liquids from electronic cigarettes. Given the role of nicotine in both the central and peripheral autonomic nervous systems, the clinical picture in these poisonings may resemble both sympathomimetic and cholinergic toxidromes. Sedative or hypnotic. The hallmark of this toxidrome is sedation. In severe ingestions, a state of general anesthesia may be reached with the loss of tone and airway protective reflexes. In addition, it may cause hypothermia through suppression of muscle metabolism. It is well known in the emergency departments because ethanol intoxication is frequently seen. Other agents such as barbiturates and benzodiazepines will also cause similar picture. Similar to sedative, the opioid toxidrome also involves sedation and a diminished respiratory drive. With the notable exception of pentazocine and propoxyphen, this toxidrome causes pupillary meiosis. The diagnosis is confirmed by noting a response to naloxone, a direct opioid receptor antagonist. However, because certain opioids have higher potencies, a lack of response does not exclude opioid intoxications. Furthermore, this is a clinical diagnosis because not all opioids will be detectable by the standard drug screen. A state of serotoninergic excess defines this toxidrome, and it is often precipitated by the addition of a new serotoninergic agent or a substance that interferes with the metabolism of a previously tolerated agent. Typically described with selective serotonin reuptake inhibitors and monoamine oxidase inhibitors, it has been reported with cyclic antidepressants and atypical antipsychotics. Consequently, serotonin syndrome typically occurs with hours to days of introduction to a new medication. The manifestations of serotonin syndrome include altered mental status, hyperthermia, and agitation, as well as hyperreflexia, clonus, and diaphoresis. Similar to serotonin syndrome, neuroleptic malignant syndrome also presents with altered mental status, hyperthermia, and agitation. However, unlike serotonin syndrome, peripheral muscular effects tend toward rigidity and decreased reflexes, rather than clonus and hyperreflexia. It is due to dopaminergic depletion due use of dopamine antagonists, such as antipsychotics. Now we go to our second question, general principles of acute poisoning treatment. The general management of poisoned patients involves providing appropriate supportive care, undertaking decontamination or enhancing elimination if indicated, and providing specific antidotal therapy where an antidote exists and is indicated. Antidotes do not exist for every potential poisoning, and thus supportive care is the cornerstone of managing the poisoned patient. Following the basic ABCs of resuscitation by ensuring airway protection and adequacy of ventilation while maintaining the circulatory status of the patient, with fluid resuscitation and vasopressor support in the prime focus. Vascular access needs to be obtained with the peripheral and central venous catheters. Once supportive care has been initiated and the immediate threat to the ABCs has been stabilized, one should then progress to a systematic assessment of decontamination strategies, enhanced elimination, focused therapy, antidotes, and getting help, consultation. A few words about decontamination again. As you know, decontamination is the process of preventing systemic absorption into the body. In the case of ocular or dermal exposure, this is achieved by copious irrigation with water after removal of contaminated clothing to expose the area. Inducing emesis with the syrup of ipecacuanha is not indicated in the care of any poisoned patient in the emergency department. Why? Syrup of ipecacuanha use is associated with significant side effects. For example, dehydration due to intractable vomiting and complications. For example, aspiration pneumonitis, Mallory Weiss tears, and gastric rupture. There are also insufficient data and evidence showing improvement in clinical outcomes. Gastric lavage, the process of directly removing an ingested substance from the stomach using orogastric tube, also has little data or evidence showing its effectiveness and should not be performed routinely for the treatment of poisoned patients. Please, students, pay your attention to this slide. It is very important, and I hope it will be interesting to you. Historically, single-dose activated charcoal has been the mainstay of gastric decontamination in medical toxicology. Activated charcoal is a carbonaceous substance that has been exposed to high heat and steam, resulting in a large surface area to volume ratio to provide ample surface space for ingested substances to absorb, and thus decrease absorption into the body. The benefits are more likely to occur if the activated charcoal is administered within 1 hour post-ingestion. Next, the patient is alert, able, and willing to cooperate with administration, and anticipated to remain alert and protective of airway reflexes. Next, the substance ingested has high toxicity. For example, verapamil, colchicine, or is a toxic substance sustained release agent. And next, there is evidence of a massive ingestion of a toxic agent. If the patient is sedated, has the unprotected airway, or is unwilling to drink the charcoal suspension, and with administration is contraindicated. This may be particularly true for young children with a limited ability to drink the slurry. Furthermore, one should not place a nasogastric tube solely to administer activated charcoal, because the risk of aspiration or direct installation of activated charcoal into the lungs rises in these patients, thus tipping the risk-benefit ratio. In this slide, you can see potentially lethal toxins where early activated charcoal administration may be indicated. They include cyanide, colchicine, calcium channel blockers, cyclic antidepressants, cardioglycosides, cocaine, and others. And pay your attention to the next slide, substances that do not bind to activated charcoal. Activated charcoal is ineffective against pesticides, heavy metals, acids and alkalis, iron, lithium, and solvents. The next procedure, the whole bowel irrigation. In certain ingestions, such as extended release preparations, illicit drug packets, or metals, for example, iron and lead, continuous whole bowel irrigation may be indicated. Whole bowel irrigation is performed with a balanced polyethylene glycol solution that does not participate in fluid exchange nor become absorbed into the body. To be effective, it requires a rate of 2 liters per hour in an adult. Consequently, this will require nasogastric tube placement. However, if a patient is critically ill, has hypoperfusion of the gut, or has obstruction of the bowel, whole bowel irrigation is contraindicated. Now we go to the next question of this lecture, antidote therapy, or how we used to call it, focused therapy. Although the majority of poisonings require supportive care alone, in selected ingestions, specific antidotal therapy may be available. Evidence and experience support the use of several antidotes, which should be available either immediately, for example, stocked, or in a rapid fashion, transport within a few hours. Here you can see the classification of antidotes. You can see that according to mode of action, we have physical antidotes, chemical, and physiological. And according to mechanism of action, we have 7 groups of antidotes. I suggest to describe it one by one, this lecture. Here you can see the most frequent antidotes that are used in our hospitals. Let's consider them more deeply. Physical antidotes, what is it? Agents used to interfere with the poisons through physical properties, not change their nature. And the main example is activated charcoal. The next mechanism, coating. A mixture of egg and milk, for example, makes a coat over the mucosa. It can be effective in corrosives, but not in cases of organophosphate. It decreases efficacy of acids. And dissolving, the next mechanism of physical antidotes, dissolving. 10% alcohol or glycerin for carbolic acid. The more interesting maybe will be for you chemical antidotes. The mechanisms are oxidizing. Amyl nitrite is used in cyanide toxicity. Methylene blue, it is used with methemoglobin procedures. Nitrates, phenacetin, chlorates, sulfonylamides. Vitamin C, used for drugs causing methemoglobin. Physiological antidotes, or we call it pharmacological. The mechanisms are antagonism. That can be competitive antagonism. One of the greatest example is naloxone. Opioid dependence, loner action with affinity for mu receptors. And flumazenil, antagonist for benzodiazepines. In this group, we can note atropine, organophosphate, carbamate, and other parasympathomimetic. One more mechanism is non-competitive antagonism. For example, anticonvulsants for treatment of convulsions. Calcium gluconate used for calcium channel blockers, especially verapamil, black widow spider bite, lead colic, and oxalic acid. Pralidoxime, cholinesterase activator by breaking the alkyl phosphate cholinesterase bond. It is used in organophosphate toxicity to form an oxime phosphate complex and leaves the cholinesterase enzyme activated. Contraindicated in carbamate toxicity because of short duration of action. Hishistigmine, counteract the anticholinergic effects such as in severe atropine toxicity. Chelating agents unite metallic poisons to form soluble, non-ionizable, less toxic, and easily excreted chelates. For example, dimercaprol, or how we used to name it, British anti-leucide. Next, calcium disodium edentate, EDTA, unites with the metal which takes place of its calcium. It is water soluble and may be used intramuscular or intravenous. It allows extracellular lead to be renally eliminated. Dimercaptosuccinic acid, DMCA, the best for lead chelation in children with lead intoxication. Next, N-acetylcysteine, antidote in acetaminophen toxicity that often used in children. There are many other examples of antidotes, but I hope you will take this information from our practical classes. And now we go to our final question, complex detoxification. Once a toxin has been absorbed into the body, it undergoes metabolism and elimination, typically via hepatic and renal pathways. Certain substances are amenable to enhancing these elimination pathways, either ex vivo, as is the case with hemodialysis and its related therapies, or in vivo, as is the case with the multiple dose activated charcoal and urinary alkalinization. Forced diuresis. It is a simple method for some poisons. It is a fact in increase with the manipulation of urine pH. It is efficient only in poisons with the following properties. As you see, substances excreted mainly by kidneys, then substances with low volume distribution, and substances with low protein binding. Types of forced diuresis: fluid diuresis and osmotic diuresis, using mannitol 10%. And some words about manipulation of urine pH. This method acts depending on the extent of ionization and can be forced alkaline diuresis and acid diuresis. Hemodialysis and its related therapies are best suited to remove poisons of low molecular weight, low protein binding, and high water solubility. Examples include toxic alcohols, lithium, and salicylates. All forms of extracorporeal removal have been studied and found to be effective. The selection of the specific type of elimination modality ought to be made based on patient-specific factors and early consultation with nephrologist in conjunction with a toxicologist. Here you can see the plot with dialysable toxins. The main of them are salicylates, theophylline, barbiturates, lithium, and ethylene glycol. Peritoneal dialysis acts by considering peritoneum as a semi-permeable membrane, but has complications: intra-abdominal bleeding, perforation of abdominal organs, peritonitis, dehydration, or overhydration. Contraindications are pregnancy, abdominal hernia, or respiratory distress. Hemoperfusion, using equipment and vascular access similar to that for hemodialysis. The blood is pumped directly through a column containing an adsorbent material, either charcoal or amberlite resin. Systemic anticoagulation is required, often in a higher doses than for hemodialysis. And thrombocytopenia is a common complication. Because the drug or toxin is in direct contact with the absorbent material, drug size, water solubility, and protein binding are less important limiting factors. So please pay your attention for conclusions to this lecture. The main of them are: patients with severe toxicity, such as seizures, persistent cardiovascular instability, airway compromise, or significant metabolic derangements, should be admitted to an intensive care setting. Patients who are asymptomatic or arrival but have ingested a potentially dangerous substance that could cause significant deterioration in their clinical status are admitted to either an inpatient setting or an observation unit for 24 hours, or until peak toxicity has obviously passed and the patient is physiologically normal. For patients who are asymptomatic after an ingestion of a minimally toxic substance and for whom other ingestions and psychiatric issues have been addressed, discharge after the emergency department visit is appropriate. We can make more easy conclusions, and it will look something like that. It's better to avoid poisoning than to treat it heroically. Thank you very much for your attention.